Okay, I'm sorry. I apologize for that.
Okay.
So, all
She's
right.
coming up now.
All right, so we have Dr. McMillan coming on as well.
Beverly McMillan.
Beverly McMillan. Okay, well, welcome to the program, Getty.
Thank you.
So you are the founder and CEO of Sisters in Birth.
Clinic. Mm-hmm.
Okay. And you're a population expert, as I understand it, health expert, author, and a mother.
Mm-hmm.
All right, so what do you have to tell us about abortion in the state of Mississippi in particular and health care for women? It is my understanding you are involved in that, and of course we had an abortion clinic here in the state of Mississippi. It's now shut down.
I don't have anything to say about abortion. I'm really tired of talking about abortion. I mean, it's interesting to me that the only time reporters have shown any interest in the birth disparities that are widespread in Mississippi, that have ranked the highest in the nation for decades, is when abortion is at the heart of the issue. So I'm really talked to death about abortion. It's done here and in many places across the country. And in 2020, there were 5,089 abortions among Mississippi residents, but there were also in that same year 5,071 premature births. And I'm here to talk about the premature births and the low birth weight babies and the C-sections and the horrible care that women are getting and the conditions that lead to poor birth outcomes. That's what we do. We intervene as a community-based clinic using midwives and community health workers to improve the woman's health, state of health, and her outcomes, the outcomes of her outcomes as well as those of the baby.
And your organization has been around since 2016, is that right?
I've been doing the work before then, but officially the business was created in 2016.
Okay.
Mm-hmm.
So how do you get the word out? How do expectant mothers, how do they find out about your services?
Well, number one way is to Google. For women who need free pregnancy testing, we offer that, for instance.
Mm-hmm.
Or a woman knows she's pregnant and she needs care. She's looking for prenatal care. She may be looking for childbirth education classes. She's looking for a midwife. She's looking for a clinic that's going to spend more time with her, that will provide her with more support. And that's what distinguishes my clinic from all the other clinics probably in the state of Mississippi. We're the only clinic in the area that has a midwife, certified nurse midwife. And the certified nurse midwife spends more time with the patients. She shows more interest in the patient's overall health and health issues and social issues that we know impact her health. She drives 2 hours to my clinic. She works with us part-time. But women call from across the state because they're looking for a midwife. They don't want the OB and they don't want to deliver their babies in a hospital. They've had horrible experiences. They don't want to be induced. They don't want C-sections. And we have the highest C-section in the country every year. Particularly among black women, which has increased by 63% since 1994 and 33% among white women since 1994. And we are the C-section state or capital of the country. It's good business for doctors, good business for hospitals, but it's horrible health care for women.
And so what do you attribute that high rate of C-sections to? Well,
that's a very good question. Well, unfortunately, many doctors in our state are performing C-sections that are not medically necessary. What the research shows is among black women, they've never had a baby. The baby's not breached, which is the number one reason, medical reason for a C-section is usually the mother her health is at risk, or the baby's health is at risk, or the baby's breached. Well, in most cases regarding black women around this country, the baby's not breached. There's no medical indication. It's the first-time pregnancy. She's young, so there's really no medical reason for the C-section. But because a doctor wants to put her on a schedule, he or she will induce her, and the induction often leads to a C-section, particularly among black women.
Why do you think that's happening more in Mississippi than in other states?
Well, because Mississippi hasn't taken any steps to stop it. And in some states, the state... I'm just going to say this. In some states, the leadership, public health and healthcare leadership, have put some interventions in place to prevent it from happening. If you look at the Mississippi State Department of Health data and you look at numbers of non-indicated inductions and C-sections, you will see the numbers, the percentages continue to climb. I think it was in 2014 that the March of Dimes launched a campaign to convince doctors to stop that behavior. When that campaign ended, it was business as usual. The state of Mississippi hospitals have earned over $228 million on average every year for C-section. It is the number one surgery in this country. And when a woman has her first C-section, there's an 89% chance she will have a second and a third, because doctors will not allow her to even attempt to have a vaginal birth after a C-section. That's a major surgery that can lead to hemorrhaging, infections, and infection is the third leading cause of women dying after having given birth in the state of Mississippi, followed by hypertension and heart disease. So it's convenient for a doctor to schedule a woman to be induced during the week. Most births in this country occur during the week. That's interesting to me, because that's not a baby's schedule. That's a doctor's schedule. They want to have the babies delivered during the weekday, not at night.
Let me make sure I understand. So you're saying that this high rate of C-sections you're attributing to convenience for doctors.
Convenience for doctors, money for hospitals, but primarily convenience for doctors.
Okay.
I talk to women all the time who tell me they were induced and they don't know why they were. They
Gotcha.
had no medical underlying issues that would lead a doctor to say, let's induce you, or we need to perform a C-section.
So I'm trying to understand, though, and Dr. Beverly McMillan has joined us as well in the Element Well studios. I'm trying to understand what's different about Mississippi. What policies do we need in Mississippi, since we have such a higher occurrence of C-sections than other states? What are the other states doing that we're not? What do we need to do?
What policy do you think we need? What do you think would encourage doctors not to perform so many C-sections?
Do less inductions.
Less inductions. Mm-hmm.
And I think educating the patients that they should stand their ground and say, I'd really like to go into labor spontaneously on my own.
Mm-hmm.
Well, so are you saying then that patients in other states are more likely to stand their ground? Are you saying that doctors in other states aren't as
we're not saying any of that. We don't have research to say that.
Okay. Well, that's what I'm trying to understand.
Yeah,
what's different about Mississippi than the other 49 states?
That's a really good question. I can't tell you.
Because you're saying we have the highest, so something's got to be contributing to that.
Data shows every year.
And I'm not refuting that
whatsoever. I know you're not. I'm just reciting the data.
Because I can tell you there's a lot of people that listen to the show that make the laws in the state.
I know that.
And I have relationships with them as well. If there's some policy issues that we need to take to our government that you feel like would address this, let's do it. Okay.
I wish it were that simple, because I've taken policy issues to this government before to go nowhere.
Okay.
I've had bills introduced that weren't even called for a committee vote, subcommittee or committee vote. Yeah. Public health bills.
Can you give us an example?
I can. Yeah. I'm perfectly happy to give you an example, and I thank you. You're an excellent interviewer, and I thank you for asking these questions. There's a breastfeeding licensure bill. On 3 different attempts, I've had that bill introduced. What is the purpose of breastfeeding licensure? Mississippi also has the lowest breastfeeding rates. Now, we know plethora of information, evidence showing that breastfed babies are healthier babies, all right? There are a number of hospitals in Mississippi that are quote-unquote baby-friendly. The problem is many women don't have access to individuals who are qualified to help them with breastfeeding. And in many instances, the hospital staff is not adequate in helping them. So let's say a woman she decides, I'm going to breastfeed my baby. The doctor didn't tell her, because doctors don't even encourage women to breastfeed.
Hold your thought. I'm sorry to interrupt you. Hold your thought. We got a break right here.
Okay.
We'll come back on the other side of the break, and we'll continue this discussion.
Okay.
Thank you so much. We'll be right back in the Element Well studios. We're visiting with Getty Israel and Dr. Beverly McMillan from Sisters in Birth organization. So where are you located, Getty?
In Jackson on Briarwood Drive.
Okay. All right, so, and we talked about this before. So you were explaining to us, and I was just trying to understand, why is Mississippi, why do we have this unfortunate distinction of having this outsized number of C-sections and inducements?
Well, before we went to break, I was giving you an example of how difficult it is to get good, sound, evidence-based public health policies, law in Mississippi. And using the breastfeeding licensure bill. Okay. The purpose of that bill was to assign licensure, state licensure, to breastfeeding experts. Many of them work for WIC, earning a very small income. And many women who should be breastfeeding don't have access to this expertise, not during the pregnancy or after the pregnancy. So when a woman delivers her baby and she initiates breastfeeding, let's say in a hospital, somebody helps her start breastfeeding. When she goes home during that second, third day, that's when she's more likely to have problems. But there's no one to help her. The hospital doesn't send anyone. No one calls on her. There's no telehealth. There's no neighbor. There's no one to help her overcome that problem with breastfeeding, all right? So it would make sense if we assigned a license to the breastfeeding experts, we could incentivize, and I want to emphasize incentivize because Republicans like the word incentivize. We could incentivize that profession to start consulting businesses and provide these breastfeeding services during the prenatal stage and the postpartum stage, when the baby is born and the woman is likely to have difficulty with breastfeeding and give up and give the baby formula, which is a huge mistake in terms of building the baby's immunity. That bill was introduced not once but 3 times, and each time Sam Mims allowed it to die, or maybe he just killed it. Now, he's been over the Public Health Committee for how many years? He's chairman of the Public Health Committee.
Yeah, I'm not sure.
And yet we can't get a meeting with him. And when someone did speak to him about this bill a few years ago, maybe the second time, he said, oh, my wife breastfed all 3 of mine. Well, good for him. That's good for him. And I bet his wife had access to the help that she needed. All right, but many women don't have access to the professional help that they need.
Okay, so I get that. So let me ask you, what incentives did you want? What was the proposal?
Okay,
I mean, monetary incentives?
Okay, listen.
Taxpayer-funded monetary incentives?
No, I did not say that.
Okay, well, that's what I'm asking.
Okay, listen. Insurance companies only recognize state-licensed healthcare professionals. If you are not a state-licensed healthcare professional, you cannot get reimbursed, or no one can get reimbursed for your services. I don't care how much of an expert you are. So
somebody's phone's ring.
So in that breastfeeding professionals are not licensed, they cannot get reimbursed for their services. So we're simply talking about passing a law that would give them state license, and then they would be recognized by the insurance industry, which would be forced to reimburse for their services.
Okay. So the insurers can't reimburse for some sort of medical services provided without proper license from the provider.
They got to have a state-issued healthcare license.
Yeah.
All right?
You know, I would take a different approach to that. I sort of disagree with the need for a license.
Well, tell the insurance industry that.
I hear you, and I know the insurance commissioner, and I will. So.
It's not up to the insurance commissioner. I've already been down that path.
Well, the insurance commissioner suggests law and is involved in overseeing the regulations, but it's the lawmakers that would have to, I agree with you, change the laws there. I get that, but those laws are administered by the Department of Insurance.
So are you saying you're going to help me to get this bill passed?
Well, I don't know anything about the bill, except what you've told me. So, I mean, I'm sure, how long is the bill? I haven't read the bill. I'm not familiar with the bill. Yeah, send me the bill. I'll take a look at it. I'm not promising that I'll help you get it passed, but
you
because
said you would talk to the insurance commissioner.
Well, no. Look, let me make that clear. Let me back up.
All right.
I have been a strong advocate of tearing down and reducing licensing requirements and reform for licensure in this state across a number of disciplines for quite some time.
Okay.
I think we have too many licensing requirements, too many boards that issue licenses.
Okay.
And I think it is a barrier to work. And I think it's a barrier to good outcomes. That's all I'm saying.
Okay,
so,
but the insurance company will not reimburse.
I get it.
Okay.
Well, I don't always agree with the way insurance companies operate
Neither do I.
So,
Neither do I. But that's their policy.
But it's not that I'm ready to just kick them to the curb either. They provide a valuable service, but these are just nuanced issues that maybe we can overcome. But it sounds like what you're advocating for is a new form of license.
What I'm advocating for is for breastfeeding experts to be in a position so they can be reimbursed for their
which means they got to have a license.
Which means that the insurance industry won't budge until they have a license.
So I'm assuming the bill that was killed in committee that you talked about, I assume that's what it would do, is it would create this new license.
Right, but it's not for the purpose of regulations, it's for the purpose of getting paid.
I get it, because the insurance companies won't reimburse.
They won't reimburse.
I'm with you. I understand. And I'm not necessarily blaming. I don't know all the details from the insurance companies either. We don't want people out there, I think, that are providing services that are reimbursable, I can see where they would be concerned about protecting their interests, where just people show up and say, here, I did some services here, reimburse me. So, but then you get into all kinds of complicated coverage issues, and then there's network issues and things like that that get pretty convoluted. But okay, so that's one policy matter. Mm-hmm. I get it that you are a proponent of, that you'd like to see happen in the state of Mississippi. What else?
Well, we go on, Dr. McMillan.
Community health workers.
Go on.
Okay.
I'm gonna let you talk.
Tell us about that.
Okay, I think Sisters in Birth is utilizing community health services along with the medical service offered to prenatal patients. And this is what I think will make a difference in maternal fetal outcomes. They the community health worker helps the patient eat right, exercise, just takes the leading cause of most of the OB problems in Mississippi is obesity.
Is this while they're pregnant or after or postpartum?
This is while they're pregnant.
Okay.
While they're pregnant.
Yeah, I understand that as well, that we have the highest mortality rate in the country, and just infant mortality rate. Mm-hmm. And my understanding is from talking to physicians that are in that world, OBGYNs and so forth, is that a great deal of that could be prevented with proper prenatal care. Is that your view as well, Dr. McMillan?
I think that's right. But proper prenatal care involves more than just coming to see the doctor.
Sure.
It involves lifestyle changes that aren't all easily addressed in a routine doctor visit.
Okay.
So a community health worker is a wonderful evidence-based way to impact outcomes.
Okay.
Right. And
so what public policy do you want to see around community health workers?
Community health workers, their services need to be reimbursable.
Okay. Same deal. You want them to be licensed.
Let me say, no, I didn't say licensed. I said reimbursed.
Okay.
So here's the thing.
Thanks for that clarification. My apologies.
Yeah. So community health workers provide non-medical, evidence-based preventive primary prevention. What do I mean by that? Primary prevention is putting the responsibility on the patient. What is the typical patient in Mississippi is obese or very much overweight.
Yeah.
And that comes with it maternal morbidities like hypertension, diabetes, and then heart disease, okay? But those patients who come to us and come to other doctors are already at risk of this experiencing because they're coming from a general population that has the highest obesity rate in the country.
Yep.
And so most women who become pregnant who qualify for Medicaid didn't have insurance before becoming pregnant. So they're not getting primary care. There's no community-based intervention. They're just existing. And they're living off fast food, and they have sedentary lifestyles. And so now you're pregnant.
Okay, so I hear you, and I agree with you. I get the problem. Uh-huh. What policies do you want to see implemented to address those?
I've been using very successfully, community health workers since 2015 to improve lifestyle, to cause lifestyle changes among this Medicaid population, and those lifestyle changes, not gaining too much weight, eating healthy, getting off the fast food, all of that, education,
I'm sorry to interrupt you. What public policies do you want?
I said reimbursing community health workers.
And where do you want, but you said, you stopped short of saying to get them licensed, which is a requirement for insurance reimbursement. So how should we reimburse them?
First of all, the managed care organizations could do this now. Medicaid could do this now if it wanted to.
Okay. So Medicaid can reimburse without license?
If Medicaid wanted,
services provided by a licensed practitioner?
If Medicaid wanted to reimburse for these services like home visitation is a benefit of the Medicaid beneficiary.
Okay.
But because of the moratorium that's been put in place on home health agencies, we're not allowed to create an agency and take advantage of the home visitation benefit.
Okay.
All right? There's a lawsuit right now on behalf of a physical therapist who sued the state of Mississippi because he can't take advantage.
We got a break. Let's come back after the break. I want to hear more about what you say about the distinction between Medicaid and private insurance and how this fits into that structure and what changes Medicaid could do.
Okay.
All right. Appreciate it. We'll be right back. We got the folks from Sisters in Birth here in the Element Well Studios on midday. Stay with us. Studios back with you. We've got Getty Israel, the CEO of Sisters in Birth, and also Dr. Beverly McMillan, Medical Director of Sisters of Birth. So please continue on, Getty, what you were saying about the managed care organizations.
I was talking about the managed care organizations that receive huge contracts, and they may not think they're huge, but we do, huge contracts from the state of Mississippi, our tax dollars, to improve the health care and health outcomes of the Medicaid population. And they have done a horrible job of reducing premature births and low birth weight babies and C-sections and inductions and all the other things, that disparities on that list. And I have reached out to their CEOs and CMOs, chief medical officers, since 2016, since I started this business, talking to them about this work and how it improved birth outcomes, collecting data to show them that it works. And Drew Snyder even encouraged them to work with me to get this program off the ground, and they wanted Medicaid to get
Drew's ahead of Medicaid.
Yes, and they wanted Medicaid to pay for this when they could very well pay for these services themselves. I have used Kellogg Foundation dollars, Humana dollars, AmeriGroup dollars, CareSource dollars to provide free services, these community health services, to members of these 3 managed care organizations, including Blue Cross Blue Shield, state of Mississippi employees. And I can't get the state of Mississippi or any of the managed care organizations to pay for these services that significantly improve birth outcomes. All right, so Drew is not Mr. Snyder's not stopping them from paying for these services. They simply want the state to pony up more money to pay for these services. They want to refer their members to me to get free services. And yet they walk away with a mint for their stockholders.
By they, you're talking about the MCOs, yeah.
Exactly. So now here we have a new contract coming up. You know this already. The Medicaid will be announcing new contracts, and I think there'll probably be 3. And I'm very hopeful, very, very hopeful that AmeriGroup and CareSource, which I think is working with the hospital group here, will get one of those contracts, because those 2 companies get community health. They understand the value of integrating clinical care and community health to improve health outcomes, particularly among the Medicaid population. They understand why it's important to do home visitations and health education and advocacy and coaching and everything, and labor and delivery support and breastfeeding support. So if those 2 organizations manage to get a contract with Medicaid, then these services will be paid for. But the 3 existing organizations, nothing has come of it, not anything.
So, obviously, you've approached the MCOs about this.
Since 2016.
Okay. What do they say? What's their response?
Well, Molina dug its head in the ground and said, we have no problem, when this is the same organization that reached out to me asking me to join some committee to help them to address their problem. They have a very high premature birth rate. Mississippi Magnolia said that they would prefer to hire more nurses than to pay for community health services, even though they've benefited from it. Blue Cross Blue Shield, you can't even get them on the phone. It's like trying to reach into a prison. And United Healthcare came to the table in 2019 and walked away from the table. So who knows?
All right, once again, other states, how do they handle this? Because Medicaid's a shared state and federal program.
There are managed care organizations like AmeriGroup, like CareSource, that are operating in other states and are trying to come here that will pay for these services.
Are they participating in the bid? Do you know?
Yes, they have participated in the bid, and I hope to God that they get a contract, because they could make a big difference around the state of Mississippi improving health care.
So you're reporting now that in other states where they have these contracts, these managed care contracts for Medicaid services, that they are allowing these services to be included in coverage. Is that right?
And there are other MCOs that do this type of work.
Right.
This is not anything new. We're not trying to create a new wheel here.
Okay.
And I have introduced the vice president of marketing to the chief medical officer of United Healthcare in 2019, the former chief medical officer, to share with her how they do it and the benefits of doing it. You pay out of your administration money that Medicaid gives to you. You get 10 times back in returns when you reduce 1 premature birth. Do you have any idea how much a premature baby can cost? Employers in the U.S. paid $16 billion. $16 billion for premature babies.
I actually do, and I tell you why. Because I've had this. I've had this conversation with people at UMC.
Yeah, UMC would know.
If you've ever done the tour, and I know you have, of the neonatal, the NICU,
right?
It's mind-blowing.
Yes.
And I'm telling people that are listening right now, it is astonishing when you walk in this giant room with all these bassinets full of
Premature
babies.
babies.
Premature babies,
Right.
and an army of nurses that are caring for those babies who do fantastic work, by the way.
And it is the lead.
And when I asked the question, I just hate to interrupt. I asked the question of the physicians giving me the tour, and I asked the question, how many of these were avoidable? Virtually all of them.
There you go. You just
Virtually
took the
all
words
of
out of my mouth.
And then I asked the question about, once we exited the room and kind of, I guess, reflected on the moment, I asked the question, and he knew it was coming. I said, how much? I'm a business person. How much? I'm interested in the economics. And I was astonished at the cost. And there's a special room, as you are aware, for the really seriously ill infants.
Very premature babies.
Right. And I got to tell you, it overcame me just standing at the edge of that bassinet, looking at those teeny tiny babies with a gazillion wires and tubes hooked up to them and monitors and so forth.
And it's preventable.
To keep them alive. And then I asked the cost, and I was blown away.
So that means
we as taxpayers are paying for it.
We're paying for that.
There's no doubt about it.
We're paying for that.
And so I have a really close friend that's retired now that was a pediatric GI. Not many of those. Very rare.
I
not
haven't
many
heard
of those.
of that before.
Pediatric GI. Retired from UMC. I know him because I played golf with him for 20 years.
Okay.
All right. And he used to tell me about these costs of premature babies, and it just was mind-boggling. And that was 10 years ago when we were talking about it. So I know it's a whole lot more than that. And the only point I'm trying to make is, I mean, it's nature, and you're going to have ailments. Things are going to happen. But when it's preventable, just with proper prenatal care, this costs a lot of money. We're all paying for it. I'm for whatever we got to do to eliminate those costs
And you would think,
improve outcomes. health
Yeah, you would
outcomes
think
too.
the managed care organizations would get that if you invest in prevention on this side, you will reduce the likelihood of a woman producing a premature baby. They don't get that.
I mean, on the surface, I'll say, Getty, it makes sense to me, economically speaking. But I'm not privy to all their analysis and what drives their decisions. But I hear
stupidity drives their decisions.
Well, I'm not going to go that far.
I'm going that far. I'm going that far. That's stupidity.
I think it bears discussion at a minimum, and
not when you're in denial about it. They're in denial about it.
Okay.
And
Fair
who's
enough.
paying for their denial? We are.
I hear you.
We're paying for that. I got to get out of here.
I know you do. You told me
But
that
I enjoy
appointment.
talking to you.
Well,
I'll come
I
back.
appreciate you coming in. We'll do it. We'll do it again.
Okay.
And it's been very informative and very enlightening. And at a minimum, wherever you stand on this, folks, it's a discussion we got to have because our outcomes are not good. That's the bottom line. Is
And we're paying.
we have bad outcomes, and we're all paying for it. So we got to do something. Dr. McMillan?
So let's try something new.
Right.
I'm with you.
Let's try
I'm
the
with you.
community health workers, which have been statistically shown to work
Around the world.
Around the world,
Around
they
the
have
world.
worked.
I'd like to see us get all the subject matter experts and all the stakeholders at the table to have a discussion about this, to come up with some solutions that make sense that we can all live with.
I wish you well on that.
Well, okay.
Bringing those people together.
Don't underestimate me.
I don't underestimate you. This isn't about you. I'm talking about the state.
I hear you.
You know what I mean.
I do.
I don't even know you to underestimate.
I know you don't.
I like that you're open-minded already.
Okay, well, fine.
I enjoy talking to you.
Okay, so all I'm saying is the conversation we had today, I think this needs to occur in a setting where people who make decisions and have power and authority can do so. That's all.
Okay, I'll be there when it happens.
Okay,
if I'm invited.
You would make sense to me as a person in the in the trenches that could be valuable in the discussion.
I'm in the trenches.
But in fairness, now I'm sure there are people on the other side that have a different viewpoint.
And
than
I've
you.
heard those viewpoints.
Well, they need to be at the table
and
too.
it's pure stupidity.
Okay, well they may think yours is though. That's the only point I'm trying to make
and
here.
they don't want to spend the money for the outcomes. They want the state to pay for.
Okay.
I've heard this conversation many times since 2016.
I got
they
you.
want the state. Ask Drew Snyder. He was on the call with them.
I know Drew, and I'll follow up
And
with
he
him.
made it clear to them that he wasn't giving them any more money to pay for these services. And he told them they need to, and they
he
need
does
to.
have some degree of control over that, but most of that's, of course, done in law and in the making of our Medicaid.
Let me say this one
regulations.
last
okay,
thing.
we got to go. We hurry up.
Medicaid requires some basic things.
Yeah.
All right, of the MCOs. It does not stop any MCO from going beyond that point and providing more services.
I'm with you.
That's the last thing I want to say.
Fair enough.
All right.
Appreciate it.
Thank you.
Thank you guys for coming in. Thank you.
Call me anytime.
All right. Appreciate it.
To the clinic.
Thank you. Be careful. Good luck. See you. Thank you. All right. We'll take a break right here on Middays, and we'll come right back with the